So with that, I'd like to go ahead and start us off by introducing Alex Mugge. She is the Director and Deputy Chief Health Informatics Officer in the Division of Burden Reduction, and she'll be talking and giving us some context around CMS's perspective on the topic of patient access APIs. Thank you very much, Alex.
Thanks, Ziad. Thanks everyone for attending today. If we can go ahead and go to the first slide. I just want to take a minute to talk through how we got here and where we are with the APIs, particularly in the context of some of the CMS regulation, but also broadly like where we're going. So much has happened in the last 5 years leading up to the use of these APIs in healthcare. The work of the organizations that are represented here today has really contributed a lot to the work that CMS is doing to put some of these APIs into regulation. And FHIR is a relatively young standard. It has gained a lot of traction in the industry because of the variety of uses and its incredible adaptability of its resources. But really, I feel like in the last few years, it's really kicked into high gear. And we at CMS and our partners at ONC have really looked at FHIR as an opportunity, to align industry on a single open source standard that is adaptable to the many programs and the needs that we have in healthcare. CMS has been looking at FHIR for many years, but it wasn't until the last few years that we really started to integrate FHIR into our regulations and our programs. And even we have even integrated FHIR into our own operations internal to Medicare fee-for-service. So in large part, this has been possible because of the work done in industry, such as the Da Vinci and Karen collaborations and the work that has been done in this space. CMS and ONC have been observing this work for many years, and because of the work that you all have done to accelerate FHIR, we've now been able to include that work in our programs and in our regulations to align industry towards a common direction. The first, broad example, I guess, that I would say that in which we have adopted FHIR into our regulations is with the interoperability and patient access final rule that was published last May. We've also begun to integrate FHIR into the many aspects of CMS's work with Blue Button, with our own quality programs, and our own documentation requirements lookup service. But today, I specifically want to talk about these interoperability rules and the use of the implementation guides that are available to support implementation of those rules. So the first rule, as you see on the screen, I think you've all seen this slide before, but we love it, so we're putting it up again. So this timeline represents the first interoperability rule, the CMS interoperability and patient access rule, with a heavy emphasis on patient access. And this rule has gotten a lot of attention over the last 2 years, and we're finally now approaching the first implementation deadline for payers. July 1st is that deadline, and on that date, the impacted payers of this regulation will be required to implement the patient access API and the provider directory API. And this is the first time that CMS is regulating the use of interoperable standards for payers, and that's a big deal in my opinion, and I'll get to that a little bit more in a second. But I just want to highlight that when we're talking about impacted payers for this regulation, we're talking about Medicare Advantage plans, Medicaid and CHIP fee-for-service entities, Medicaid and CHIP managed care, as well as the qualified health plans on the federally facilitated exchanges. So while this doesn't cover all of the payers, and by extension, therefore, does not cover all patients, we believe this is a significant step towards engaging payers and their larger parent organizations in the use of FHIR-based APIs for data exchange interoperability. So we would hope that, while we are regulating certain plan types through this regulation, that payers would choose to roll out these APIs to all of their lines of business and not just those lines of business that are impacted by these regulations. So I mentioned that this is the first time that we are regulating payers in this interoperability standard space. And so why is that important? This rule really represents a shift away from our historic focus on EHR interoperability and the use of EHRs by clinicians and hospitals, and it puts our focus more onto payer interoperability and sort of interoperability in the broader healthcare landscape. So by really engaging payers in this world of data exchange and moving data with patients, we're shifting away from that concept of accumulating data in silos, and we're moving more towards this space where data follows the patient. And that is, I'll speak more about that throughout this presentation, but that's really getting at the heart and the intent of these rules, is to ensure that not only do patients have access to their data, but it follows with them on their healthcare journey. So I think it's important to note that in this first rule, we did not require the use of specific implementation guides or the APIs that we finalized, but we did point to, and we continue to encourage the use of several APIs to support that implementation. So for the patient access API, we encouraged the use of the Karen for Blue Button IG, the DaVinci PDEX IG, and the PDEX formulary IGs. And these IGs together provide some technical insight that will help payers to be compliant with the requirements of the interoperability rule. And then, of course, for the provider directory API, we also encouraged impacted payers to use the PlanNet IG to implement that requirement. So we're looking forward to the July 1st implementation deadline and the rollout of these APIs to patients. And the success in large part of this is due to the collaborations of these organizations and to the folks on this call who have engaged in the development of these IGs and engaged in the work to accelerate FHIR and its many uses. So I do want to highlight one other thing that we did in this rule. The next deadline for implementation for payers is January 1, which sounds much farther away, but is right around the corner. And that is the deadline to initiate the payer-to-payer data exchange. And this policy provision, I should be clear, did not require the use of an API in the rule. We talked about the different ways that payers exchange data currently, and we specifically did not require the use of an API for this data exchange. But we did require that payers begin to exchange data between and among one another at the patient's request. And this policy really gets at the goal of getting data flowing and encouraging industry to explore ways for patients to bring their data with them as they navigate their healthcare journey. Patients shouldn't lose access to their data simply because they move from one payer to another or they change providers. They should always have access to their information and their healthcare history right at their fingertips. So this policy, I believe, was very clear on its intent. It was clear on the intent of having those patients bring their data with them when they change payers. However, we have heard from industry that in some cases, the fact that we were not clear about the mechanism for that data exchange has been challenging for implementation. And that's in part why we chose to address this policy again in the CMS interoperability and prior authorization proposed rule that came out last December. So I'm going to talk a little bit more about that rule and our transition to that rule from here. So with the CMS interoperability and prior authorization rule, so this proposed rule, again, it was proposed last December, has not been finalized. It is in fact pending review under the new administration. So hopefully more to come on that soon, but in its proposed form, we did continue the momentum of the first interoperability rule, and we built on those APIs that we established in the first rule. Some of the policies that we crafted in this second interoperability rule not only address the payer-to-payer data exchange API that I just mentioned, but also were put together primarily in response to stakeholder feedback that CMS has received through our own research and outreach. We've conducted over 35 prior authorization listening sessions and interviews, and we've monitored various industry efforts related to reducing the burden of prior authorization, including the ICAD task force with ONC and many others. This work is not new to industry. Folks have been talking about the challenges of prior authorization for many years, and CMS took note of that. And Mary Green, the director of our Office of Burden Reduction and Health Informatics, spoke about this yesterday morning in her talk. So hopefully you all got a chance to hear some of that and get a little deeper dive on the burden reduction efforts and the prior authorization work that we've been doing. So, but getting back to the rules, the CMS interoperability and prior authorization rule expanded on the policies that we had in the first rule and introduced new provisions that would expand the use of APIs as well as streamline prior authorization for CMS regulated payers.
Hi.
It's important.
Good. How you doing?
Oh,
You too.
sorry, I think someone's not quite on mute back there. But
Folks on
hopefully y'all can still hear me. In this second rule, I just want to highlight the regulated payers that are included. We regulated through this rule the Medicaid and CHIP fee-for-service, or the state Medicaid and CHIP state programs, and the Medicaid and CHIP managed care payers, as well as the qualified health plans in the federally facilitated exchanges. Notably absent from this rule was Medicare Advantage payers, but we did note in the rule right up front that we would be exploring similar policies for Medicare Advantage plans in future rulemaking. So I just want to keep that in mind. Through this rule, we did move beyond patient access. And actually, this is probably a good time to go to the next slide, which is more of our roadmap forward. Because with this second rule, we moved beyond patient access to look at the broader challenges of healthcare data exchange. Patient access is, of course, critical, and it was first and foremost in our drive for interoperability. But to truly get to data exchange to the point where it can benefit patients with better outcomes, we also have to ensure that data is flowing not just to patients, but we have to ensure that providers, payers, caregivers all have access to the data they need when they need it most, so that that data can work for providers and can work for the healthcare industry, allowing them to make better informed decisions about patient care. You know, it's really, we've spent so much time on adoption of EHRs and the documentation of data, but we don't just document data in patient records for the sake of writing things down. We document data in healthcare to help inform healthcare and make it better. If the data isn't flowing with the patient, then it can't help facilitate that better patient care. And then what good is it? You know, we're not just documenting so that the provider can look back on their notes, but if that patient's going to another provider, that provider should also have access to those notes and really make use of this information for better patient care. So the policies in this rule were intended to utilize that data exchange and to streamline what was once a very burdensome process in healthcare to help facilitate better informed and more timely access to care through improved information exchange between providers, payers, and the patient. So all stakeholders in industry, and thus helping those players make better informed patient healthcare decisions and better manage that patient care. So I'll just give you a quick overview. I don't have a handy timeline slide for Rule 2, but I can give you a quick overview of the provisions that were in that proposed rule. So first, we did propose to expand on the patient access API from the first interoperability rule by adding prior authorization data to that patient access API, therefore increasing the transparency of that data and ensuring that patients have a better lens and scope into prior authorization and what's been involved in their care and making those care decisions, hopefully in a way to help them improve their discussions with their providers and with their payers in regards to their own healthcare access. Next, we proposed an entirely new API, an API that would provide for data exchange between payers and providers. We call that the Provider Access API. And this API would allow for data to flow from the payer directly to a provider, allowing them thus a better insight to their patient's healthcare background, not just with their own practice, but where the patient has been before that, and what are some of the procedures that they've had before coming to that provider. Then we also had several policies on prior authorization and burden reduction. Specifically, we proposed 2 APIs in this space. The documentation requirements lookup service allows providers to view documentation requirements or prior authorization requirements directly in their EHR workflows. And this API utilizes the coverage requirements discovery, or CRD-IG, as well as the documentation templates and rules, or DTR-IGs, which we did actually propose to require in this rule. More on that in a moment. We also proposed the prior authorization support API, which uses the FHIR standard while maintaining the integrity of the HIPAA transaction standard for electronic prior authorization. So really allowing a provider to do electronic prior authorization transactions directly from their workflows in their EHRs. And this prior authorization support API uses the prior authorization support IG, or the PAS IG, as indicated by its name. So also some work that has come out of this organization to support more streamlined healthcare data exchange. In addition to the APIs, we also proposed several requirements that would reduce the overall burden of prior authorization. I won't give an overview of all of those, but for example, one of those was reducing the timeframes for prior authorization decisions. And this is critical because it really gets at the heart of some of the challenges that can't be solved with technology solutions, but still true challenges to the prior authorization process. And we provided these as sort of guidelines for how to improve prior authorization. We certainly expect that payers could go above and beyond what was proposed in this rule, but that some of these guidelines are a start to a way to improve this otherwise historically burdensome process. And then finally, I wanted to highlight that we did propose a payer-to-payer data exchange on FHIR, so using an API for the payer-to-payer data exchange policy that was finalized in the first interoperability rule. And this was really to get all payers, through this rule now having APIs to exchange data with patients, with providers, as well as with other payers, all through a FHIR-based API, and setting those standards and aligning those common standards across those different APIs. We did receive a lot of comments on this rule. Many commenters said we didn't go far enough. Some commenters wanted shorter timeframes for prior authorization, and some suggested policies that would require providers to integrate these APIs into their workflows so that the electronic data exchange could be supported on both ends of the transaction. And we hear those comments and understand where the commenters are coming from. We always appreciate getting comments on our proposed rules. So I again want to highlight that unlike in the first interoperability rule, we did propose to require the use of the implementation guides in this rule. We also received comments on that, and we are taking those into consideration. So overall, I think this rule really represents a good example of setting expectations and a number of baseline requirements. Like I said, we put out some of these baseline requirements for prior authorization with a full expectation that payers can go above and beyond it. They can roll out these policies to all of their lines of business. They can look at shortening prior authorization timeframes themselves, but this gives sort of a baseline of what we would hope to see in industry. And we made the intent of these policies pretty clear. We wanted to facilitate standardized electronic data exchange that will improve healthcare and timely access to healthcare services. That doesn't mean that that's where these policies have to stop. That is, again, like I said, a baseline or a starting point for where these policies can go. And from there, we expect industry to take this and run with it and go further with data exchange through innovation. So why is all this important? And why are we putting these rules together and working so hard to collaborate with you all in industry and making these regulations? And we truly believe that the landscape of healthcare is changing. People in general have much higher expectations for technology in their daily lives. Many of us don't go to the bank anymore. You do your banking directly from your phone. You don't go to you don't call a restaurant to make a reservation or call a cab to get where you're going. You do everything from your phone using an API. So why wouldn't we have those same expectations for ease of access and streamlined data exchange in healthcare? It's only reasonable to expect that this would extend to something as important as your healthcare information. And these rules help to align industry on a common direction that will help us get there. But again, they should really be looked at as the floor or the baseline for the potential in this space. I know that we're going to open this up to the panel in a moment, but I just want to highlight sort of an exciting move that I mentioned in my talk on Monday as well. And that is that I believe we're moving away from this program-based idea of interoperability. It's not just about meeting meaningful use requirements anymore or meeting the specific requirements of one rule and the API requirements of those rules, but we're really moving more towards this environment of looking at interoperability on the whole. Not interoperability for clinicians and hospitals anymore. It now includes payers, it includes researchers, it includes Medicare fee-for-service and the work that we're doing in our own operations. And this is truly critical for reaching true interoperability and moving again away from just that programmatic look at interoperability and focusing more on what is the larger goal and mission. So while we look at these regulations as a way to keep this conversation going, we always want to ensure that regulation is acting as a catalyst for innovation and is not stifling industry advancement. So if there were no more regulations in regarding interoperability ever in the future, and I'm certainly not promising that, but if that were the case, we would really expect from this point forward for industry to pick this up and keep the momentum going and keep pushing to ensure that we are continuing to promote this standardized data exchange and this use of new and innovative and aligned technologies that will help us to get to interoperability. So with that, I'm going to turn it back to Viet and the panel discussion. Thank you.
Thank you very much, Alex, and thank you for your support and CMS support of Da Vinci and the work we're doing to advance FHIR. In 20 years of doing interoperability and along with my colleagues, I don't think I've ever been this hopeful about the transformation of healthcare using APIs than I am over the last year or two, and very optimistic about the future.